Okay, cool. So thank you everyone for joining us tonight. For those of you who haven't met me, my name's Ashrit and I'm the research coordinator at Smiths. I'm super excited to be joined today by Dr. Kogan here from USC, and she's here to speak about her recent research on aging and older individuals experiencing homelessness. So she's going to be giving a presentation, and then after that, we'll leave some time at the end for like discussions, questions, and conversations around this research. So with that, I'll turn it over to Dr. Cohen to get started.
Great, thank you. I just sent a request so I can share screen. I do have some visuals for today.
Perfect.
Perfect, thank you. Okay, here we go. First, I just wanted to start out and just thank the Student Coalition for the invitation. I'm just really pleased to speak with this group. I love this group and all students who are interested and also doing research with this population where my heart lies and is the majority of the work that I do as an assistant faculty member at USC and as the director of research for USC Street Medicine. And I also wanted to start off by acknowledging that this particular work that I'm talking about today, or it's a particular paper actually, that was a student-led research study. And so I wanted to acknowledge Anuva Mittal, who is a co-author on this and really took the lead. She was a MS1 medical, first year medical student when we started doing this work and doing these interviews and data analysis. And she is now an internal medicine resident, staying in Los Angeles. So just working with students and research in general is just really close to my heart and really close to the work that I'm presenting today. Also, I did want to start out by saying, the work that I'm going to share today is a qualitative research study that we did. And so some of these slides are a little bit dense with text. So instead of reading the visuals or, really being engaged with the screen, I really invite you to kind of just sit back, relax, and listen. Hear the words of the patients and providers who we interviewed here. And then I'm happy to share my slides, after we're done here. And then I also wanted to start the presentation by describing a little bit of the language that I'm going to be using tonight. When I'm referring to people in our study or patients who are seen by street medicine, I usually call these people experiencing unsheltered homelessness. And that's because that's the term that they have told us and our team that they prefer to be called, either that or homeless, versus some of the other terms that might be thrown around or used quite often. So you'll hear me say that tonight. Secondly, USC Street Medicine specifically follows the definition of street medicine outlined by the Street Medicine Institute. And so we provide, health and social services that were developed specifically for the unsheltered homeless community, delivered directly to them in their own environment. And so we really are different than mobile medicine or any other types where we are truly doing the model outlined by the Institute. And then lastly, in this presentation, I will focus solely on unsheltered homeless adults who were in our study. But just really making the distinction here in shelter status between those who are experiencing sheltered status or sheltered homelessness and unsheltered homelessness, residing in a place not intended for human habitation. Okay. No disclosure or no conflicts of interest to report. I did have some funding from the medical school dean to do this work at USC, and then a HRSA grant to do workforce development. Okay. And then lastly, the objectives of tonight's talk is that, after attending, I hope you guys are able to describe the health characteristics of older adults experiencing unsheltered homelessness and recognize the variation of health characteristics and outcomes among that population, especially compared to sheltered homeless or housed older adults. And then also to be able to interpret the unique needs of this particular population and how that might apply to informing programs and policies and services that we might tailor for these individuals. Okay. So first, kind of to ground us a little bit, when doing this type of research, we think, who is an older adult? And so when we look at some of the typical cut points that are used, we find that they're largely driven by social programs and other types of norms. So typically an older adult we might think is someone who qualifies for Medicare. So they're 65 or older. But there's other programs with different eligibility, like, Social Security, you might be a little bit younger. If you're going to think about contributing or, taking down from your retirement savings, you're a little below 60 on average. We find even more variation in age or threshold for older adult when we consider getting, a discounted breakfast at Denny's or discounted ticket to the movies kind of thing. But in research among house populations, we typically find that we use 65 as the age cutoff. But the problem with that and the rest of these sort of age-driven thresholds is that they're really based on the aging trajectory of housed people. And they're underpinned in the assumption that one's chronological age is the same as their biological age. So a chronological age is truly the number of years you've been alive, and your biological age is sort of that, it's an estimated value of the condition of your body, your tissues and cells, and does that correspond with your chronological age? So the assumption of some of these age-based criteria is that it's equal. But we know in the research sometimes that there are instances when someone's chronological age is higher than their biological age. And so in this case, someone might be 65 years old, but you're like, gosh, they look great, functionally, or their lab readout, they're doing quite well. They're in very good shape, that physically they're closer to like a 55-year-old. Or the opposite is what we find actually in homelessness research, specifically with unsheltered homeless, where someone's biological age estimation, that number is actually quite a bit higher than their chronological age. And so we see in the research that actually there's a 20-year difference biologically or physically in someone who's experiencing unsheltered homelessness versus someone who is housed. And so that's really significant because at chronological age 50, that person who's on the street is actually functioning closer to a 70-year-old housed person. And so this is a real big issue when someone isn't eligible for Medicare till much later in life, till around age 65. So there's this gap in ability to, be eligible for services. And some of the reasons that are attributed for this 20-year, discrepancy in chronological and biological age is that individuals' poor or lack of access to healthcare, adequate nutrition and hydration over the years, just constant exposure to outside and elements, that sort of weathering of the body and skin, and then sometimes even related to substance use. And so when we do research with the unsheltered community, we're really drawing the line at age 50 plus. And that's what I'll talk about with our sample today. We see that in the numbers that people who are older, it is the fastest growing segment of the homeless population, and that they really do grab the attention a lot of the public and also media. Here's some headlines from the last few years about the graying of the homeless population. And the research shows that this is not just due to aging of chronically homeless individuals, but since COVID, we've seen the highest growth in people who are older who are becoming homeless for the first time. And so those sort of two factors together have really contributed to a growth in this population. So looking at the research on prevalence, the latest data from the point in time count show that about 30 people in Los Angeles County, not 30 people, 30% of people experiencing homelessness in Los Angeles County are older adults or age 50 plus. And that out of older adults outside, the majority are unsheltered versus sheltered homeless. And it is the fastest growing segment of the homeless population nationwide, like I said, but particularly in Los Angeles. But looking at more localized data from the California statewide study of people experiencing homelessness by Margot Cushall and colleagues, they actually found that their estimates of older adults or in their sample was closer to 44%, so quite a bit higher than the point in time count. And that if we look at the age breakdown of that 44% of participants in their study, we find that the majority are in that sort of 50 to 64-year range, again, pre-Medicare eligible, and then more of a fraction of those older adults are 65 plus. Oh, and there's the study. When looking at the health status of unsheltered older adults compared to sheltered homeless and housed older adults, we just find that this population just overall across the board has just a greater number of chronic conditions. They experience geriatric conditions prematurely. So as clinicians, we see this coming, or we see the onset of these conditions earlier than what you would have expected for someone of that chronological age. We find premature mortality among this population, the greater odds of having a physical disability, and related to that is also greater odds of using a piece of durable medical equipment, so a cane sometimes, but mostly a walker or wheelchair, which has important implications, not just for someone's mobility, but it's also this sort of visual indicator of vulnerability for that person. And so we do find increased victimization and abuse targeting older adults in particular, but certainly those who have durable medical equipment. And then we also find that this population uses the emergency department more frequently than any other homeless population or segment of the population, and that's more often to result in an inpatient stay than a discharge from the ED. Okay. At USC in particular, we do find these higher rates of older adults compared to the point in time count. And so our data last year in our program, we had 2,451 individual patients under our care. On average, the age is about 44 years old. But we take care of patients as young as 90 and as old as 18, so like a very large range there. But looking at those who are aged 50 plus, it's about 39% of our overall patient census, which is on the higher side as well. And so typically for all of our patients, we see that in one calendar year that on average, they're receiving about 11 and a half visits. So about, one visit a month kind of thing, although the median number of visits is 3. If we zoom in and look at our older adults in particular, we're seeing that within a 6-month period, they're more likely to be seen about 13.6 times. So almost like twice a month, really. And on the median number of times to be seen in 6 months is 4. So much higher touch from the street medicine team. Which we can likely infer for more acute and serious needs needing our attention more often. The other demographics among our older adults is that they're typically identify as male, and then Hispanic and Latino, followed by Black or African American, and then white. And then 84% of our patients who are older do have health insurance, although we find very few, and I don't have the number here, but it's like 12% report having seen a primary care provider in the past year. So having insurance does not necessarily indicate access to care, which is where street medicine comes in. Okay. So looking at the research study that we're talking about in particular, in true street medicine fashion, we went to the people because we wanted to know what is it like from older adults and street medicine team members providing care. What is it like to age and get older when you live unsheltered outside? And what is it like to manage serious illness when you live outside? And so we pursued this question by interviewing patients who are 50 plus and seen by Street Medicine. And then we also interviewed 8 of the Street Medicine team members that provide care to those individuals. And so we had, a semi-structured research protocol that we used to guide our interviews. And we followed sort of a modified grounded theory approach where we did constant comparison and independent coder consensus. Okay. So out of our 16 participants, like I said, 8 were Street Medicine team members, 8 were patients. For the patients, we intentionally collected very few demographics because sometimes I just find in research papers and studies, sometimes adding additional demographics serves people's sort of biases or assumptions about this population and sort of clouds judgment a little bit and gets into the way of the message of the paper. And it's not, necessarily important or integral to interpret the results. So, which ended up, I could even speak later, ended up being sort of a thing with the reviewers, but anyways. But on average, among our participants, our team members were almost 40 years old, whereas our patients were 56 and up. We had good diversity in terms of gender for our providers. With patients, it was more like representative of the patient population of older adults that we see, where the majority were identifying as male versus female. Ethnic identity of our providers was fairly diverse, as was their role on the team. And so we were glad to get several participants from the different key roles on our team, being prescribers, so either MDDO and PAs. And then we did have some representation from nursing, community health workers, and then an occupational therapist who was working with us. Our team member participants, some of them were fairly new to USC, but not new to the space of caring for people who were experiencing homelessness. So the qualitative analysis for this study revealed 2 overarching themes. The first being challenges caring for older adults experiencing unsheltered homelessness, with sub-themes relating to the challenges that had implications with medical, interpersonal relationships, environmental, and systemic and systems level barriers that got in the way to care. Our second theme had to do with shelter, long-term care, and end-of-life planning among older adults experiencing unsheltered homelessness. And so our sub-themes for that were around permanent shelter, rehabilitative and institutional care, or like skilled transitional care for individuals, and then end-of-life planning. So now we'll go into each of those with a little more detail. Okay. So in terms of challenges caring for older adults on the medical side, we found that our participants from the team members side really identified lots of challenges caring for older individuals and that they had multiple comorbidities and multiple health challenges sort of co-occurring at the same time that added both an interesting but also a challenging complexity in the care of those patients. Also implicating that complexity was often having an unknown health history for these individuals, that both from on their family side, they weren't aware or didn't know if there was any family history of particular conditions, in addition to their own health history, because they hadn't been seen by a provider in a very long time. And so one of our providers even described this engaging with an older patient as opening Pandora's box. That you're starting with one condition and it just sort of turns into there's another one, and it's just very complicated. They also described the need to have very person-centered and reality-based sort of clinical decision-making, especially for older adults. And this was really true when it came to prescribing medications, and that we, can't just sort of screen, diagnose and prescribe, that it was really like, okay, what am I prescribing? Because what is that person's access to, hydration in general, but, water to take a medication, food to have with that medication, The availability of a bathroom. They describe, diuretics as sort of one of those common, medications for an older adult. But if someone lacks, consistent or reliable access to a bathroom, that could be a real problem and challenge for someone. Same thing about lack of refrigeration for particular medications. Um, and those types of things. And another provider described like having a diagnosis as a privilege. And by that, they meant if their patient knew that they were diagnosed with something, that was really a unique and privileged position because that person had received care, they had been screened, that there was some type of diagnostic testing for them to receive that information. So they already felt like they were had a leg up or in a good sort of position. Also related to medical, I'll click back one second, was about competing priorities that people have in general when they live outside unsheltered, but especially with older adults. One of our doctors said, I worry that things that are easily preventable or treatable in a different setting will end them up in the hospital, that it either gets ignored intentionally because my priority today is making sure my stuff is still here when I get back from panhandling, or that person attacked me last week, I got to move my stuff. That's going to take priority over, oh, it kind of burns when I pee. But it can easily become a full-blown septic picture easily, especially if their sort of baseline health is already lower. Another sub-theme that came up was a challenge related to interpersonal relationships when you live outside, and that overall, both our patients spoke to this and the providers spoke to the older adults, sort of being a little more isolated socially, usually by choice, but sometimes just, because of age and connection. But that this can really have implications due to complicated street relationships, and that a lot of some relationships on the street that the older adult would foster because they needed help, getting water or food or a particular resource. And so some of these relationships were transactional in nature, but it also leaves that older adult in sort of this vulnerable spot by having this dependency on someone who could then sort of shift things into victimization or withholding of things. Um, and so, the providers in particular, but the patients without calling it this, really describe this double-edged sword of having relationships where, sure, that knocks down sort of the social isolation a little bit and connects you, with people, but there also could be that negative side where sometimes not all those relationships were positive health-wise or in support of positive health decisions, and also leaving that person, like I said, vulnerable or in this precarious situation. Also, the idea or the concept of ageism came up quite a bit, where older adults, again, we talked about that like visual sort of symbol of vulnerability, or if you're in a wheelchair, you can't chase me if I steal your stuff, sort of thing, that older adults were targeted in that regard. And then things like if someone was older, the assumption that they're collecting a Social Security check also came up, in that they would be perhaps victimized because the assumption was that they had some money. Okay. The environment, as you might imagine, is very challenging as it relates to aging and maintaining the health of an older adult in particular. And some of the field notes that were collected out during our data collection period had notes such as the following. Interview conducted at tent located under a freeway overpass. Another one, the interview took place, they were situated behind a gas station near an off-ramp located in an open air with few trees. Another person's encampment was, the tent was on a sidewalk and located between two driveways. Note, this patient meets legal criteria for blindness. Another was the area is very quiet between two mountains with few passing cars, so few eyes on this person. So, really describing an environment that isn't necessarily conducive to health and healing and aging and health management. One of our patients described, having challenges with being asked to constantly move all the time. And they said, it's hard because, like, where do you go to actually rest? where do you go that you can just do nothing and not be told to move and move and move? And so this person was on a particular medication where they really needed to get some reprieve from the summer heat. And the providers encouraged them to access air conditioned areas. And they're like, that's great, but where can I actually go for that? And so that really has implications for their physical health if have their situation exacerbate and sort of turn acute. The last something that we found was systemic challenges or systems level challenges to maintaining health. And we really found up and down, both through patients, sort of anecdotes and those team members, that bureaucratic red tape, especially as it relates to health insurance, gets in the way often in very significant ways that really results in someone's health exacerbating to a point of needing higher care than street medicine. And so some of that was with insurance, not understanding what your coverage is, where to access care, or what primary provider you've been assigned to, having access to your vital documents, such as an identification or a birth certificate, in order to get enrolled or to adjust your enrollment in a way that would better meet your needs. And then also as it relates to medications, and that many of our patients reported, and then the providers described this too, of medications being lost, destroyed in sweeps or with weather conditions, or being stolen within, before a 60-day before a 30-day threshold for getting a refill. And so when someone needs the medication but now can't access that medication because it's been too close to the last refill to get it, we have significant implications for health. In addition to stigma that patients described and providers described hearing about, patients having to access traditional care in hospitals, or having to go to a clinic or things like that, and really having the perception of being treated poorly. And then that has implications of them not wanting to go back again, or not, feeling like they've received adequate care there in the first place. And so, that really stays in someone's mind, especially if they're encouraged or having a need to access this care later on again. Okay. The second main theme that we found was related to shelter, long-term care, and end-of-life planning. And that we found when it comes to permanent shelter, there are few options in Los Angeles for our older adults in particular, but also that our providers were really supportive of having sort of an expedited pathway to permanent shelter for older adults in particular, and that does not currently exist in Los Angeles. But they also talked at great length about, sort of shelter and a roof, like not being like the one answer to everything. And that once you do get someone who's older inside, that there truly is a need for wraparound services, and caregiver supports, because it's not uncommon that on the street that person was relying on other people to meet other needs, like for getting their water, getting their food, things like that. And so now we take them and move them inside. They still have a need for things like water and food. And so we have to be very mindful and make sure that these needs are still being met with it for individuals. Same thing about that social connection. We did talk earlier about not all social or street relationships are in support of someone's health, but it's still a social relationship, right? And so when you do cut someone off from that world or remove them from the outside world where they came from, we do need to be mindful about that. I thought there was something I want to, let's see. Yeah, okay. The next subtheme was about rehabilitative and transitional care, and that we found that for many of our older adult patients, that there was really an inadequacy and a lack of availability of temporary shelter. And so sometimes our patients are not sick enough to go to the hospital, but they're also too sick to really be on the street. And so there's sort of this gray area where something like medical respite would be perfect, or, at least better, nice to have that option. And we just really don't have that very thoroughly thought out or available in Los Angeles. And so that came up quite a bit in the interviews. and that those sort of temporary shelters that are available, that they're really not age or ADA, so Americans with Disability Act friendly, and they're not person-centered. So oftentimes we heard stories from providers or patients saying, something became available that they needed, but it was on the second floor, and this person has a wheelchair and there's only stairs. There is no elevator, and so they can't go inside. So what we have is just inadequate and not, frankly, against the law, even in some instances, but still just not meeting the needs of individuals. And there really seemed to be this sort of chicken and egg conundrum where among our older patients, those who had the greatest sort of medical need to go inside were least likely to be able to do so because they were considered medically complex, and these sites did not want to take someone on who was considered medically high risk like that. And so the street medicine team is really like stuck in this conundrum and balance of the thing this person needs the most is shelter right now, and that's almost the last thing that we can get for them. One of the PAs said, "Our emergency sheltering systems are not designed for older adults. Shelters get scared off by medical complexity. If they feel like someone is too medically complicated for them, they won't allow them to stay in the shelter." The last subtheme that came up all the time was around end of life planning, and that both street medicine providers and patients, they really discuss death and dying quite a bit, and that it was really described, especially from the patient side, as feeling like not in control, and that death felt to be inevitable, but that you kind of had no idea when would it be coming. One of our patients told their doctor, they said, "I don't want to die on the street. I know I'm going to die soon. I just don't want to die on the street." And so being surrounded by peers having passed away or receiving terrible diagnoses and dying very quickly, it's really around them all the time, in addition to just accidents for anyone of any age. And so patients really did express how they felt the need and really wanted to communicate their wishes. And it was interesting because their wishes do, of course, it's a very personal thing, but on the whole, wishes seem to diverge a bit from housed populations, and that our patients really described a need to document and sort of share what they wanted, what wanted to be done with their remains and their possessions. Where with housed populations, we see sort of different priorities and values when it comes to end of life planning. But this sort of willingness and wanting to communicate about their wishes to team members sort of coincide with team members having this sort of realization that the way they were trained to elicit someone's end of life values, preferences, and do the documentation, they were all trained in a sort of a housed population setting, so in hospitals, in clinics, and things like that. And when you're engaging in end of life planning with someone who lives outside, that was significantly different. And so across the board, our providers expressed that they would like more like street specific training with end of life planning and communication with their patients outside, or ways to kind of communally discuss this and come up with our own best practices if nothing exists right now, for training in this area. Let's see. One of our PAs had a really good quote that I thought. They talked about the luxury of a diagnosis again. So they said, "It's a luxury to know that you might not survive a diagnosis that you have. You had the luxury of having a diagnosis and having a prognosis that may be able to decide and maybe being able to decide what you do in that time." I think anytime patients have a heads up, if there are things that they wish to do, wish to reconcile, wish to get right with, that they have that opportunity. And so as street medicine providers, they really felt this weight, and they called themselves secret keepers, that their patient was comfortable and willing to divulge certain secrets with them. But then they being the only one that knew this information. And so that was a really heavy responsibility. because they were, with your street patients, you're more likely to be the person to carry out those wishes. Versus a hospital setting, you might be eliciting those, but you're not likely to be the person to carry those out. And so they talked about how nice it was to, if you actually know or have a prognosis and diagnosis that's time limited, that you can do something with your life versus the, other feeling that our patients described of, sort of not having control, not knowing when this is going to happen, yet it feeling inevitable. It's this odd like crunch. And then lastly, the challenges around hospice, and that one of our PAs described trying to obtain hospice for one of their patients, which it did not work out to get hospice on the street. And they said one of the main issues though with hospice was that he needed oxygen. And there's a lot of problems with that. You can imagine there's no electricity, but he also cooked over an open fire. And so we couldn't find a durable medical equipment company that would say, sure, we'll bring an oxygen tank next to the side of the freeway where you cook over an open flame in a residential neighborhood, by the way. Since we've done this research, there are some hospice agencies that are starting to focus on this community. But we really need to work on this or, continue in this avenue because we do find the great need among our patients in light of the challenges of their environment. Okay. So just sort of wrapping up here with discussion is that, other research really well documents the high disease burden of this population. And so our sort of interviews and adding the voice and context really confirms the challenges of navigating this high disease burden when you live outside, coupled with having really reduced options for support and for housing, even though you need it the most. And that really distinguishing shelter status is really important as it relates to having competing priorities. They're very different if you access a shelter every night that may have a bed, a toilet, a shower, running water, maybe even a breakfast as you leave in the morning. That's very different than being outside. And so if we are able to shelter our folks, we really need to be mindful about what wraparound services are available because there's going to be significant holes in their care. And that, really sort of a way or an area that research needs to focus is that sort of transitional care piece for people experiencing unsheltered homelessness, both from, having been in a hospital and then discharge, what does that look like, accessing like recuperative care, things like that. But then sort of that non-acute, but not able to be outside sort of situation where medical respite is a great need. So sort of transitional care spots for people who live outside deserves attention. And then, like we said, specific clinician training that's sort of street-based, that not all of our clinicians or many of our clinicians, they receive their initial training in traditional and sort of housed populations. But as, you really work into this space, what are the best practices for engaging with older adults or, geriatric street-based care and things like that? And how can we learn from each other in this area? So just closing thoughts about priorities, being pertinent to survival in general for someone who is experiencing homelessness, but with older adults with a very precarious health situation, they have significant implications like we talked about. Number one being the environment having massive contributions to the aging and illness and sort of victimization of these folks. And so it does inform our street medicine sort of model a bit in that, we kind of have to think about, especially for this population, how can we be nimble and does following patients help, or, what might we do to be responsive to the needs of this particular population? And shining a spotlight on environments that are person and age friendly and centered, to really support someone's safety but autonomy at the same time in a way that is meaningful to them. And then reconsidering these 8 chronological age-based criteria, right? If someone who's 50 outside is functioning like a 70-year-old, but they aren't able to access social services for 15 more years, that's a very big challenge. And so we ought to rethink that and further explore that for this population. We really need to focus on having our person-centered, community-focused sort of approach to street medicine, which is sort of inherent to the model, but also in the research that we do. and it should be community engaged, where we are eliciting the voice of those patients or that particular population of interest, and using their voice to inform everything we do every step of the way. And I put here, lessons learned from little r or big R research. Big R research is, what we think of sort of this like federally funded grants or these like large projects that, there was a proposal and a big plan, which is amazing. But frankly, the funding environment is very difficult these days, and, other challenges to do research. But little r research is just as important. And so little r research is what I call, kind of the street medicine care we do every day. It's the anecdotes you hear from your patients, and it's the provider who's like, I wonder about XYZ, or, observing something around with your patients and, having further inquiry. That's not funded work or funded inquiry, but it's super important. And that little r research can lead to big R research. And so it should not be discounted. And frankly, those boots on the ground perspective is absolutely invaluable to doing, subsequent work. And then just aging and managing illness outside is, challenging on the whole, or on a whole, but, really whole person approaches are imperative, and thinking about how a one size approach does not fit all. And what does that mean for your patient in particular and older adults? So just in closing, sorry, it looks like my animation is not working there. I'll fix it. But I was sharing the citation of the paper that I just presented to you. But also, interestingly, since this is a student meeting, I wanted to share sort of a learning experience that I had related to this work. Is that we published this research I just shared in 2025. And then 6 months later, I got contacted by the editor of the journal, which is the Journal of General Internal Medicine, saying, "Oh, we received a letter to the editor about your work, and we invite you to reply." And I had never received one of those before. A letter to the editor is that someone can write in about your paper. Typically, someone, like they compliment the work and have some type of like meaningful like addition or like supplement to the work that you've done. But in this case, it was interesting. It was several physicians from Poland that wrote in with some significant critiques about our sort of research design, and interviews, and saying, 16 people is not enough, and things like that. And so it was just sort of the learning experience was, that was a very like odd and peculiar sort of response to the paper, coming from a country with universal health care and, it's sort of systems and a hospital-based physicians, which are very different, and they don't have street medicine, and trying to apply research methods that are more appropriate for housed populations, and trying to apply that to a homeless context. I, kind of wrote a very strongly worded rebuttal about thanks, but this is absolutely egregious. And I just wanted to bring this up to support all of you doing research with this population of, sometimes people will put our work down and suggest that it's not as rigorous and that we're using, methods among a population that can't possibly consent to research or provide answers because they have altered medical status, mental status, and things like that. And I just want to encourage you all and give you an example of, please stand up. I'm sure you will do, but stand up to those types of criticisms. Our work is valued and it is valuable, and we are doing it in a rigorous and scientific way. And so don't let people try to suggest that you don't. But it was very odd, and I was not very happy about it, but glad that they published the response. Okay. Lastly, I have a plea, actually, is that if anyone here is doing research or publishing research specific to the unsheltered homeless population, my ask is that you include a keyword that is unsheltered homeless. And the reason for that is I've petitioned to the national libraries to include unsheltered homelessness as a mesh term. MESH stands for, I can't even remember right now, but it's like medical indexing language. And so right now, the only key word that is considered a MESH term for homelessness is ill-housed person, which the research does not support that that's adequate to distinguish our different populations who live outside. And there's growing body, really showing the health discrepancies. And so we're almost there. They declined my petition saying we only have 85 publications that have a keyword of unsheltered homelessness. And until we get to 100, they won't consider adding it. So please, if you do this work, add a keyword of unsheltered homelessness. All right. I'm just going to click through my acknowledgments with co-authors, both at USC Street Medicine and USC in the medical office or in the dean's office, and a mentor at Stanford. And I'm just going to share my contact information, and I'll stop talking there and I'll open the chat now. It looks like, oh, someone was just commenting. Okay. But I welcome your questions and any discussion items now.
Um, I had a quick question about it. I was just wondering, are there like any kind of actions that like street med teams or like clinicians or policymakers are like starting to take now that this issue is kind of coming more to light with like papers like yours being published, to address like some of these gaps in care?
Are you talking about the unsheltered piece or with older adults?
The older adults.
Yeah, I think, as people, it's turning out to not to be common that people are caring for more older adults than the point in time suggests. And so I think it's really gotten everyone's attention that, okay, my older adult patients are unique, and that, but then what do I do? Some of these, a lot of providers, not only were they trained in traditional settings, but not maybe a lot of geriatric care in particular. And so there are some subgroups that are recognizing that, and, writing research grants, and trying to get some work done about, okay, well, what is street geriatrics then? If we know what that is for clinics and we know what quality metrics look like for geriatrics, what does that mean for our patients? And so I feel like it's starting to work, or starting to go in that area. The previous research that's largely led by Margot Kushel from UC San Francisco is fabulous. It's a great start. It's a lot of like social services and sort of reasons for becoming homeless, but it lacks a little bit of the medical piece. And so, sort of this new infusion of a specifically street medicine approach to, addition to her work is sort of where the field is going. And it looks like it's, really being received well. Yeah. Renee.
Yeah, hi. I just want to say I really appreciate joining your group, and I think I kind of crashed your party. And I don't know how to say this because I'm not a student. I'm actually a director of a little outreach team up here in Washington State. I work for a tribe. Um, but I'd love to join if that's possible. I just basically, you had me at aging unsheltered homelessness, and so I just logged in for this, and it was really interesting. So, our little team started as like wound care mobile team out in the street with a lot of care coordination. And I work for a tribe, so we specifically focus on tribal members that are unhoused and try to get them into transitional housing, and then like primary care, dental, mental health, or substance use, which is where our program lives. Um, but I don't know if, because this is a research work group, so I don't know if I even belong here, but I just want to say I appreciated crashing your party, and I love it. I mean, that's great. But I think we went to a street medicine conference, and that's maybe where I got linked in with you guys. I mean, I just get emails, and so, whenever there's something that may help our team, I just join in, and I'm more of a implementer, I guess, or I'm a doer, I guess. So like if we're not doing something, we're always looking for how to improve our program.
Yeah, not crashing at all. I'm sure Ashrit and some of the others can get you connected and yeah, take that conversation offline. Yeah, welcome.
Kogan, sorry, I had a question. This was kind of related to the previous question. First of all, thank you for the presentation. It was amazing. It definitely shocked me how the 20-year age gap is like so significant. And maybe you don't have this answer, but is that significant enough to kind of change screening tools that we use in like primary care clinics? Do you think it's significant enough for us to have to like, oh, add an extra screening or risk factor, like if we do cardiac exams, things like that? Or is that research kind of still ongoing?
That's a great question. I mean, I think my my answer would be yes, that is enough to, especially go off your suspicion or, as you're evaluating patients, like don't just use age as like, oh, you're not due yet, or we don't do that yet kind of thing. Consider it like what would be the harm. I feel like the piece where the field is, we don't have, new or specified requirements around that. So it's not there isn't something standardized to say if your person is 50 do XYZ, like that's not there yet. But I think as a provider, use your clinical judgment, and I think you can do things earlier than suspected, just because that is like the sort of the pathology and the progression that we're seeing outside is that that acceleratedness. We see that a lot, especially with some of our cancers, and that once we do screen for a particular cancer, that it's the staging is well beyond what we would have expected, and we could have prevented that, or perhaps if we had intervened earlier, or if that person had gotten care earlier. And so I think we're going there, to probably changing guidelines and requirements, but we're not there yet.
Are there any other questions?
Is anyone
Okay.
doing research, or in general, not necessarily with older adults, any research that you'd like to share?
I can share. I'm with Loyola Street Medicine, and I'm doing a research study with others on we asked our patients where they would go to receive care if street medicine wasn't here. And we found that like 62% of our patients would have gone to the ED. So that's the research I'm involved in, and just like looking at all the different chief complaints, like retrospective analysis for the last like 4 years for Loyola. Obviously, wound care was a big one. So that's yeah, that's what I'm doing.
That's really interesting. We had something similar, or like a piece of a research project we were doing at USC, where we ask about that, about where you would receive your care if not from street medicine. And then also we were follow up to that, we were asking them to like rate that care, sort of like a 5-star Yelp review. And then would you go back there? And so a lot of times they said hospital, as like you said, Savannah, like the number one, but then the how did you rate it? It was very poor. And then would you go back there? And they said yes, but because it really suggests like that's the last resort, like truly, like they know they felt like they got poorly treated, or and it was likely to happen again, but it's the last option kind of thing. And so but it's valuable and interesting, right? Especially as you sort of make a case for street medicine, or if you're looking at, like you said, the top reasons or the diagnoses, then that's really good to know.
Thank you. I guess I have a question from a student perspective, seeing patients who are older adults, like what other, I mean, you kind of touched upon this, but like what other considerations from a student perspective should I be thinking about when I have an older adult patient, just on street medicine in general when I'm interviewing them?
Sure. I think, and I'll start by saying I'm incredibly biased in this regard because one of like sort of the passion research areas for me is like advanced care planning and advanced directives and things like that. But, so that is my bias. But I will say, my opinion would be really those like values conversations. It doesn't like advanced care planning is not defined as like we completed an advanced directive, so we did it. Like an advanced directive is just like one thing you can do within the spectrum of advanced care planning. So I think normalizing these conversations of having value driven care, and again, this is great for older adults, but it's for everybody, both because this is street medicine, right? What is bothering you today? How can I help you today? But also because it's not just age that we're finding that you might expect someone to die, if they're older, we'd expect them to die. It's truly at any moment, any of our patients, young, old, might die. And so having and normalizing values conversations with any patient, but particularly an older adult, I think is super invaluable, especially as, someone knows, like when you see them that day, like if they're not feeling well, like if you notice sometimes like the conversation might get emotional just because, they're not feeling good. They might be feeling like, you know, anyways. So I just think having it part of your regular care, especially with an older adult, that would be something I think would be, you would never like it would never be a waste of time like focusing on that or intentionally including that in your encounter, I'd say.
Thank you.
And then sorry I joined late. I had another meeting before, but my name's Megan. I am the co-director of Street Medicine, which is basically a collaboration between all the medical schools in Georgia. But we are assisting with a research project right now through East Tennessee University. And it's basically looking at how individuals who are experiencing homelessness decide where to seek care, why they choose to utilize street medicine versus go to the ER, and if they find a difference in any stigma they face depending on where they receive care. And so it is a cross-sectional study, but it has multiple sites, and I'm not sure if the PI is looking for additional sites to obtain some data. So if anyone wants to connect right now, I can see if that's something you're interested in and if she wants to expand the study further.
Nice.
Thank you.
Any other questions, comments, research help, anything like that? Okay. It's not, we can wrap this up. It's a little bit past 7. Thank you, Dr. Kogan, once again for taking the time to present your research. I thought it was super helpful, and I'm sure all of us really appreciated it. So, yeah.
Thanks for having me. Have a good night, everybody.
Thank you, you too.
Thank you.